There is something that happens in combat that has to do with the neurochemical release. So when you have a flood-like release of neurochemicals like dopamine and serotonin that really amp up your system, and then there's another, it's a hormone that's released called oxytocin, and it's oftentimes thought of as the hug hormone. When a person goes into combat, they have flood-like releases of these neurotransmitters as part of the fight or flight response, and oxytocin as well. So they never feel closer to anybody than they felt to the people that they experienced combat with.
So I would say approximately 8% of people that have served in the military would go on to develop PTSD. Those numbers do vary widely based on getting data from different areas. So we don't know how many people don't present for treatment, so we can't exactly have a firm number on that.
Well, some people have PTSD immediately following active combat in the war. There are others that come back and the PTSD symptoms are triggered by other life events, maybe the loss of a significant other, the birth of children. It's hard to tell what would trigger the late onset PTSD, but it does happen quite frequently and oftentimes several years after active combat.
When traumas happen, especially in the military, very few people have time to sit and process what just occurred, the loss of another fellow service person or the close call with their own life. They have to instead just get right back out there and keep going.
As people age, they begin to think about their lives, where they've been, what they've done, who they've come in contact with. And sometimes through just the natural aging process, people begin to have memories. And sometimes those memories can be stressful, sometimes they can be upsetting, sometimes it can be tied to visits. Lots of Vietnam veterans have visited the wall and rubbed names, and that brings back memories that are oftentimes painful and have been pressed down for a number of years.
Typically we see late onset when people retire, so they're no longer able to work 60, 70 hours a week, keeping themselves busy. They don't have children at home that they're trying to care for when they come home, so they have a lot of time on their hands.
It's very important to help that veteran population to redefine some of their thinking that they may have had for 30 or 40 years, where individuals naturally assume blame for the loss of their peers, their loss of their platoon members. And they say things to themselves like, if I'd only, or it's all my fault, or I should have. So when you're dealing with a population that's held those thoughts for this many years, it's harder to turn that corner. It's harder to reframe what they're thinking. It's harder to replay the memories because the memories are so crystallized.
It's not that they've had no symptoms at all and all of a sudden they just come up. Usually it's that the PTSD symptoms were fairly minimal or they were able to be maintained by other coping strategies such as working a lot. Some individuals use substances. A lot of times as you get older in age, because of health complications, you've got to make changes, so you can't use like alcohol and things like that. So that's when the symptoms that they can't keep themselves as occupied. They're not using some of the coping skills that were helping them.
So it's believed that the most effective approach is a combination of medications and therapy to help individuals. Lots of individuals have sleeping disorders, they have vivid dreams, they have night terrors. Many are affected by anxiety and depression. So we pair with psychiatrists frequently, and the psychiatrist manages the medications, and then the therapist takes care of the cognitive behavioral, the cognitive processing therapy.
Changing thoughts will help to change kind of the way you see things. We work for 12 weeks on challenging the negative thoughts that a veteran might have, like if I leave my house, I'm going to be harmed.
So we challenge their thoughts, we challenge the what ifs, the I should haves, through a process of cognitive behavioral therapy or cognitive processing therapy. where we have them look at situations in their lives that they get stuck, such as public settings, going into restaurants, having to sit with your back to the wall so you can see the door and the exit in the entire room, and helping them think through those stuck points. So something happens. How did you respond? What was the emotional consequence? And how would you like to change that going forward?
What I see here through my own caseload and through the rest of my division's caseload, we do have a lot of success. We're not trying to take away the event. I mean, the event happened, that's always going to be there. What we're doing is we're helping the individual cope better with those, with the events that happened.
I think we have a long way to go in understanding and coming up with effective treatments for PTSD. I think there's a lot of research that can be done and needs to be done. I don't think we understand the full impact of PTSD on the individuals who suffer from it, only because, unlike other disabilities, this is not an overt, obvious disability.